Hello, and welcome everybody to a very special episode of Daily Briefing Live from Revive Health. If you are a former attendee of this podcast, this is going to be a little different take for us. We are going to spend the next hour in a webinar format going over what we call rapid recovery. So thank you for joining us. First, let's introduce the folks who will be talking. That's, for one, me. I'm Chris Bevolo, Health Systems Practice Lead at Revive Health, and I'm joined by Brandon Edwards.
Brandon Edwards, I am the CEO and founder at Revive.
And you also see, but won't be hearing, at least verbally probably, from Chase Kleckner, who's Senior Marketing Manager and the show's producer. So Chase will be helping with some behind the scenes stuff, providing some intel and navigating some things in the chat function. We will talk about how to use all those tools as we go forward. So here's what we're going to cover in this hour. Again, we're going to take a little different approach. Normally we have a 30-minute show. This is going to be up to an hour, depending on the questions we get, webinar. And we're going to cover these three areas. Really what we're here to talk about is rapid recovery. So first, we're going to kind of set the scene with where we're at today, and then really dive into what we call rapid recovery, which is the phase that we're all entering in terms of how hospitals and health systems really need to focus on rebuilding their financial coffers given everything that's gone on. And then the third part of the webinars, we'll talk about some ways that we think about approaching rapid recovery. As we go through this, we definitely want to take your questions. The best way to do that is throw your questions in the Q&A tool at the bottom of your Zoom chat, and we will look at those as we get to the end of the webinar. We'll answer as many as we can. You can also use the chat function if you want to talk to Chase. If you're having issues, we've got some information at the end that will be helpful. Chase may be posting some links as we go there. Anything I'm missing, Chase? I think that covers it all, right?
No, you're good to go.
All right. So with that, let's go ahead and dive in, and I'm going to turn it over to Brandon.
Chris said if I did a good job today, I got to get a cool microphone like he has too. So let's all root for me if we can. So I want to do just a little bit of stage setting here. Right? We talk about an unprecedented financial situation, and I think it is worth taking a little bit of a step back and just considering the pervasiveness and the magnitude of this. Right? That we have all been through difficult times in our industry. We have seen hospital closures and consolidation. We've seen bankruptcies. We've seen a host of different legislative and regulatory changes over the years that have impacted hospitals. But I don't really believe there's been, at least not in my lifetime, ever been a moment where every hospital in America, whether they were heavily impacted by COVID or not, was heavily impacted by a fundamental change in their business model. And that, that has really been the suspension of elective and scheduled surgeries and heavy decrease in ED volume. Many hospitals are reporting up to 50% decrease in ED volumes, which is generally a pretty lucrative business for a lot of hospitals. And in many ways, just everything that we built our business models and our planning around has suddenly stopped. We've got a few examples that are here on the screen for you, but also HCA announced earnings today and posted a 44% decline in profit. I defy you to go online and tell me the last time HCA posted a decline in profit, period, much less a decline in profit of any significance for what are arguably some of the most sophisticated and disciplined operators in the hospital industry. So to say that this is unprecedented is actually probably an understatement, but it is absolutely something that every hospital and health system executive is looking at. Where we find ourselves right now is either about to pivot or at least planning for pivot. And we'll talk about the planning a lot more in the rest of this hour. But the sort of states beginning to reopen, probably many of you saw the news that Tennessee, Georgia, and South Carolina had announced that they were going to be reopening, or at least reopening parts of the state. Tennessee is essentially reopening all of the state except for major metro. So Memphis, Nashville, Chattanooga, and Knoxville, which are actually, I think, the only 4 cities in the state that have their own independent health departments. And therefore, it's really the mayor's call in those jurisdictions to make those decisions. But the state has, or excuse me, the feds have outlined guidelines. The states then will take a look at those, and in some cases, cities will take a look at those. There's been very clear communication from Ohio and Oklahoma, and actually since we put these slides together, Louisiana, that will be opening up the restrictions on elective and scheduled surgery. And ultimately, as an industry, I think where this is really pointing us to is the need to be ready. And we're going to share today a fair amount of our thinking on that. But it's not just our idea or just the federal government's idea. AHA and ACS have also released guidelines late last week, and CMS, I think, on the 19th, which I think was Sunday, day before yesterday. So we really have not just thinking about this in C-suites, but thinking about this more broadly across the industry, from regulatory and legislative bodies up to the White House. So some, I think, might say, let's talk about stimulus funding and whether stimulus is going to close the gap. There's $100 billion, just kind of a quick level set, $100 billion that was funded through CARES. About 30 billion of that is being distributed now. In my view, the definition of irony is that United Healthcare is charged with that distribution. And the subject for another podcast, another day, but there is something kind of interesting about that. There is another package in the works, if you've been keeping up with the news, that would have another $75 billion for hospitals, a lot less definition around that. So I think, between those two sources of funding, to be fair, we can really credit the good work of AHA and other advocates for helping to drive that forward. That said, I think there's every expectation of really two things that will be universally true. One, an uneven distribution among the systems. There's already been some news written about pretty heavy distributions to HCA, Tenet, and CHS. Some have offered that more critically. I would offer that as sort of proof of sophistication and making sure that you're tackling the problem. But the second, and probably the most important bullet here, is it's just not enough. And it isn't going to be enough. And I don't think anybody really expected going into stimulus that the feds would be making hospitals whole for this, right? That we kind of revert back to the line that the Lord helps those who help themselves. And hospitals are going to have to help themselves in this. And that's going to point us a lot to this rapid recovery that we've discussed. So you see that quote there at the bottom, stimulus covers 1 month. True, probably for many people. I would quickly caution people like, hey, let's not sneeze at that. At least it's something. Yeah. Right? We've got a month is better than a week and is better than zero. And it certainly helps to close that gap some, but it's clearly not going to solve the problem. So, I would mention one last thing is sort of where the health plans in this. I don't think that my views of the health plan hospital relationship are very well cloaked. I think that health plans can and should do a lot more. People point to United as an example of this, and it's not totally fair to United because there are plenty of other health plans, including state level Blues, sitting on massive reserves that could be used to support caregivers. Just for point of reference, United's pledged $50 million to fight coronavirus by supporting caregivers. That is about 1 day of free cash flow for them, based on 2019 cash flow. So, that compared to the sorts of investment and lost revenue that's been happening on the hospital side, pretty anemic by comparison. But we have seen them, step up at least in support of patients, perhaps more than the institutions. Ultimately, I think today's podcast is really going to be focused on what are the solutions to some of these problems and where do we go from here in this pivot.
Yeah, and one of the solutions that folks I think are kind of coming to realization won't be a full solution, and we're going to address how to even talk about this in a little bit, is the idea of pent-up demand. So we know that in terms of closing services, putting off surgeries and procedures, patients have either had those things canceled, they've been postponed, and so there's a large population of people who are going to need to come back in for treatment. But to expect that they will come back in, to just basically refill all the lost revenue, and B, that we're going to be able to handle them and new folks coming in. We are talking to health systems about the realization that that's just not going to be what we hope it should be for all kinds of reasons, right? And you see them listed here on the screen, and there's probably others. Want to spend a little bit more time with that last one, which we hear more and more about, frankly, as we're out there talking to folks. We actually did a survey, which Chase can post a link to. You can get the results. We just released them on Saturday. It's the third version of a national consumer survey. But in this version, we asked people some questions very specifically about how comfortable they would be returning to the hospital. So just want to share some data from that. So at a very high level, thinking about when restrictions are lifted, right? So as Brandon said, we're kind of all over the place across the country with where that's going to be. But how likely are you to delay care? So we've got, if you can count those dots, about 37% of people saying they're likely to delay care. Okay. Again, there's a lot of reasons for that, which we can dig into a little bit, but that right there shows you that we can't count on 100% of folks just coming back in. You know, when you think about how long they might wait, this also gives you a little bit of a feel for that. You know, some people are fine. 15% of folks are like, yeah, let me in. Now, of course, this does not account for the acuity of their situation. So if you're sitting there with a serious heart condition, you're more likely to want to move in right away, COVID-19 or not, right? Though we have seen stories and have heard from health systems about significant drops in ED visits in terms of stroke and heart attack. We don't imagine that those incidents have just gone away. It's just an example of people, even in very emergent situations, avoiding the ED and avoiding the hospital. But then you can go along the line and you can see that you're looking at 65% of people that are somewhere between a month and longer that they want to delay, right? So it puts that last slide in a little bit more perspective. And then when we go to those reasons, and I think what's interesting about this, if you want more on this survey, you could actually go and find the recording of yesterday's podcast where we had Ben Fuqua from our agency dive into this deeper. This is an example where I feel like we could have used different color scheme because we have a nice calming aqua for what is a lot of concern. Maybe that should have been bright red. For one, you can see the high levels of concern given these different fears that people have. Number one is getting sick from other patients from COVID-19. But what I think is a little tough to tell here is that the gray bar, which is some concern, we don't have the numbers showing here, but you can look at the first one and guess that that's about 95% have some or a lot of concern about returning and getting sick from other patients. The second one also, you know, I can remember joking with folks years and years ago, I've been doing this for a while, the last thing hospitals should be talking about is cleanliness. Why in the world would you want to promote your cleanliness? That's just assumed, right? Well, this is the kind of day and age we're in now where everything's flipped on its head. And this may be the first thing you need to get out there message-wise, because folks are going to be very interested. We've seen that from the travel industry where they've gone to great lengths because they are still operating, trying to help people understand why it's safe to fly, given the cleaning operations that they have. So you can go on down the list. I think one of the things too to look at just quickly is the last one, right? So if you're trying to put a positive spin on this, the least fear, according to this survey, is lack of insurance coverage. But again, you see 37% of people have a lot of concern about that. And that speaks to the level of unemployment we're seeing, the loss of health insurance, all of that. So all of this just really sets up, you know, we have got to do something. We can't count on patients coming back in. We're not going to be able to count on the payers. That's probably a safe bet. We're getting help from the federal government, but it's probably not going to be enough, which leads us really to this idea of rapid recovery, which is this phase that is coming that is going to be so instrumental to helping us financially.
So I'm going to try to set this up kind of from a time standpoint. So, you know, we have all become absurdly familiar with flattening the curve and what that looks like. But I figure there's a really great construct here actually to think about the current phase that we're in and the pivot that's coming. And couple really important caveats before we even get into this. The timing of this is really going to be different in every market and maybe even different among hospitals in the same market. I think it's going to have a lot to do with, well, first there's the overlay of will your state allow you to return, and what's the governor saying, and what does that look like in your market. I think second, there's a very legitimate issue of how many COVID patients you have or how many you're expecting to have, depending where you are in the country. And so it may be declared, safe to reopen, but your particular facility isn't there. We're hearing some health systems talk about creating sort of a designated COVID hospital, right, within their mix of hospitals, so that the other hospitals can be COVID free and address some of those patient concerns, as well as opening up ORs. But let's really agree that we put ourselves now in the dark hill on the left-hand side in crisis response. And how long the tail of that is really has a lot to do with all the factors that we just talked about. Where we're really focusing today is on that center, that orange, rapid recovery. And we have the, sort of the beginning of that tail in late March, early April, which is when we started talking about this with clients to start the planning process, with the expectation then that that planning process will lead to public communication, outward facing communication to physicians, to referring physicians, to surgeons, to patients at the appropriate time. And that appropriate time is really all about the factors that we were just discussing. And then we see a sort of a second wave, if you will, what we're calling return to growth. And return to growth here is we've sort of mapped as post rapid recovery into the end of the year. But there's an important caveat to this we'll talk about in a moment, and that is how we plan for this timing, recognizing that at the other end of this rainbow is flu, normal flu, right, that will come back in late fall, early winter, as well as potentially a resurgence of COVID that's tied to that same timing. So forget about second wave in your market that may happen in May or June or July or August or never, but also planning for that resurgence later in the year or early in 21. So with that, let's just talk a little bit about what we view as the first mover advantage in this. So let's say, for the sake of argument, that everything Chris laid out around people's concerns about coming back are real, right? That people are afraid of the cleanliness issue. They're going to be cautious about returning. I mean, my God, if you're self-diagnosing a heart attack or a stroke, let's assume elective is off the table for now, right? I mean, that sort of severity is pretty amazing. What we're viewing this first mover advantage is, if there is less food in the trough, if there are fewer surgical procedures available because there are fewer patients who are going to return or stick to those pre-authorized and scheduled surgeries, then I think that the first mover advantage becomes even more critical. Market share has effectively dropped to zero for everybody, or very near zero, on elective and scheduled. The first priority I think we can all acknowledge is getting those people who were scheduled that went on pause rescheduled, whether that's 100% of them or 50% of them or 70% or whatever number is ultimately going to be available. But the thought around first mover is that not only do you capture what you already had and what you already have scheduled, but also how can you use that first mover advantage to fundamentally reset and grow market share in your market? Or if you're already the market leader, how do you at minimum protect your market share, if not show some incremental gains over what may be the second or third mover in your market? So want to look a little bit at what the implications of that first mover advantage are, right? You've got the market share that I mentioned. I think I don't want to dwell too much on the sort of avoiding the negative, but I'll have to mention it at least for a moment. We will have all spent 3 or 4 months celebrating the heroes that work in your hospitals and in your health systems, and the people that are putting their own lives at risk to treat these desperately sick folks. If we don't get this right, one of the implications could be furloughing or layoffs among that very subset of heroes. And I've heard people say, no, it's not going to be nurses. We're going to look at administrative staff, or we're going to look at pay cuts for physicians, or whatever it is. But if there is not enough business here, we all know eventually it will turn to clinical staff, and it'll turn to frontline staff. And that will just absolutely destroy all of the goodwill and brand equity that's been created during this process by our institutions. Institutions that stepped up and did the right thing for the right reasons. We want to maintain that goodwill and that brand equity. So look at sort of avoiding forced financial restructuring. I think we just have to know coming out of this, there's going to be an increase, at least risk of bankruptcy. There's absolutely going to be additional consolidation. I think we're going to see a lot more buying and selling even than we have in recent years. I think we're absolutely going to see some people doing that almost exclusively for supply chain reasons. Right? It is very clear that not all supply chain management is created equal in hospitals right now, and that the people that are going to be prepared to be first movers are really going to be those people who also have their supply chain nailed down. So I'll mention then the last two bullets, and then we'll transition here into that later in the year phase. But one is, we know COVID is going to be back, whether it's second wave or a resurgence in the winter, and there will be a time when we may not be able to do elective and scheduled again. And so there is a window of opportunity here that we'll talk more about in a second. The last I'll just mention is that I think for some, this is going to be a question of financial survival. I've talked to a number of analysts and others who have said, look, I think this notion that you're going to recapture all that volume that went on pause is a fool's errand. A lot of that's just gone forever. And I guess my feeling is they're probably right, which makes every single case even more important, right? And not just the ones we had, but those that perhaps our competitors have as well. So let's talk for a moment about sort of the next phase of this and what the tail end of the year looks like. I would argue that even if you don't totally buy the first mover advantage, and you should, by the way, but if you don't buy the first mover advantage as a real strategic advantage here, I would argue that it's almost unavoidable to think about the urgency that is created by that second wave. If we effectively sacrificed March, or most of March, April and May, for elective and scheduled surgeries from most organizations, some will tail into June or July, some may be open up on May 1, but we've effectively sacrificed about a quarter of the year. That, let's say, just for the sake of argument, you're going to reopen June 1 for elective surgery. Gives you about 5 weeks from today to do planning, to get all of the marketing, operational, financial implications lined up. Tremendous complexity in doing things like 7-day-a-week ORs, or 24-hour-a-day ORs, or whatever the things people are talking about. But there's this window, I think, of time when, if we don't get these surgeries done, we may actually find ourselves in very much the same situation that we are now. And I think that there are two dangers of that, right? One is, if we have not taken care of that surgical volume while the time was available, the low point of this graph here, right, when there's availability, we may not be able to get to them in Q4. Most of us, not everybody, but most look at sort of the last 3 months of the year, Q4 for organizations that are on a fiscal calendar, or Q2 if you have a mid-year fiscal. But that window of time is usually when you see a Q4 surgical surge, right? You see people that they've hit their out of pocket, they've hit their deductible, they're going to get their surgery in before year end. Talked to a number of hospitals in 2019 who couldn't even service the entire surge, either because of a shortage of anesthesiologists or other critical services. But in this environment, not only may we face that, but we may also face the resurgence of COVID and find ourselves back in the unavailability of ORs. So again, I would argue, whether you buy first mover or not, this window of time, this logic, I think, is sort of unassailable. I hope to God we don't face this. Nobody wants to see this, but I don't think it's such an extreme prediction to really think about the window may close at the end of the year and may remain closed for a bit while we're waiting for an effective treatment or vaccine at that point. So, kind of with that setup, can't say strongly enough the belief that rapid recovery planning should really start right now. That, an accelerated planning process in most hospitals pre-COVID might have been 4 to 6 weeks. We are seeing hospital teams do amazing things in much shorter timeframes than they have in the past, and we'll talk more about that coming up. But I think if you leave the podcast with one thing, it is, are we starting to plan for rapid recovery now, whatever that may look like in your organization? And now we'll spend a few minutes talking about what we think it should look like in your organization.
Yeah, so I want to stop just real quick and remind people that they want to submit a question, to do that in the Q&A thread in Zoom. I know there's one question already about where this deck will be shared, and you'll have an opportunity at the end when we stop for questions to let us know if you would like a copy of it. So that'll be coming at the end. We'll also post a copy on our website as a reminder there. If you want all of our information on thought leadership, our thinking on COVID, We do have a communications hub at thinkrevivehealth.com. So definitely check that out if you want that. But let's spend some time talking about how we're thinking about rapid recovery planning from a marketing perspective. And I think the important thing to keep in mind as we go through this is there is a lot to get your arms around. This is not a simple prospect to go out there and figure out what to do. This is not an ad campaign, though that's part of this. It is not a letter to patients, though that's part of this. There are just so many different things to consider, and we have to move fast. So we're going to share some of our thinking with that to kind of give you guidance on what you should be thinking about. And the first place we think about are four main areas of assessment. What do we need to understand as marketers to be able to go out there and effectively build volume and protect volume? And the first area is, what are the priorities of our business, right? So when you think about triangulating, how are we going to prioritize patient need versus operational readiness versus service line profitability? You need to think about all of those. And again, typically this isn't the marketers coming up with this, though we hope that marketing leadership is part of the group that is determining this. But it's going to be very difficult for us to do what we need to do from a marketing perspective if we don't have clear priorities outlined at an organizational level. That goes down to payer status. That goes to all kinds of different things. Most of the systems that we're working with right now and talking to have already started this work and are moving quite fast. And you can imagine this involves operations, clinical, HR, IT, pretty much every fundamental function of the organization has to come together to figure out how we're going to reopen our doors. And in some cases, very quickly. As we know, like in Ohio, the governor's asked for those plans by the end of this week. So that's one area that we need to understand from our organization. The second, obviously, is that operational readiness. When are we going to be able to reopen? What, where, all of that. And this obviously varies depending on the kind of organization you are. So if you are a single hospital, it may be kind of an all-in situation. If you have 8 hospitals, then you may be able to shift or focus your COVID treatment in one and open the others quicker or in a broader way. What is the situation with equipment and supply status? What is the readiness of your staff, your physicians? Brandon alluded to this. You know, we have asked them to step forward in such a heroic way to save lives. And now if we're going to expand our surgical schedule, if we're going to really go about rapid recovery in the right way, we're going to ask them to, in a sense, save the financial life of the organization. So where are they at? And obviously, that depends if you're a system in New York versus Tulsa versus Minneapolis, right? But we have to understand this as marketers, if we're going to be smart, where are we going to be able to open and in what way? So we can communicate that, and we'll share a little bit more about that in a bit. What overall is the market like? How has COVID-19 impacted your market, right? Is it hit in a very severe way, like we've heard with New Orleans or New York, obviously, Seattle early on? Have you kind of moved through it in a better way as many other markets? Are you unsure? Have you hit your peak? Is the peak coming? What kind of restrictions have been put in place by the governor or by the mayor? What does the unemployment look like? Do you have major employers that have laid off a lot of people? Getting a snapshot of where you're at in terms of your market is really important to understanding where you can move and how you can move marketing wise, right? That goes to the consumer sentiment we talked about a little bit ago, the fear of coming to a hospital, and also brand sentiment. How are people thinking about you and how have you shown up? And we'll talk a little bit more about the implications of that when we move on. And then finally, where are you at in terms of marketing capability? Have you suffered losses in terms of staff, furloughs, layoffs? Have you suffered literal losses? Have people been affected by COVID-19 that has taken them out of service? How is your budget? What partners do you have in place to help you with this? Understanding all of that and being able to mobilize, again, all of this is critical to being able to actually put a roadmap in place to move the ball forward from a marketing perspective. So as you can see, we have something we can share that kind of goes through in detail. Here's all the things you want to know. It's about a 5-page document that we start with to try to understand all of this. And we need to understand it in the context of the COVID-19 situation, and we need to understand it fast. Once we have that understanding, there are any of 6 different initiatives we think are going to be critical to, again, maximizing how you come through rapid recovery. And I'm going to talk through each of these pretty quickly. Not everybody will need all of these, though we would imagine most hospitals or health systems will need all 6 of these. To what degree you need them, depending on what you've already done, what priority do you need them? Those are the kind of things that you should be thinking about. First and foremost, obviously, is we need to understand consumers. We need to understand our patient set. We need to understand the folks who are out in the market. Again, how are they being affected by COVID-19 at a surface level, but understanding them down to a household level. When we think about all the different things we need to use in terms of data marketing, this is going to be critical. And when you think about these initiatives, if we're in a normal place, you might think about them in a linear fashion. So first, we're going to do a lot of data. We're going to do a lot of research, right? And then we're going to do this. These initiatives are going to have to happen simultaneously. You're going to have to be very agile and very flexible in how you move through these. You're going to have to know some of this to move on some of the other initiatives we're going to talk about. But you can't wait to do 3 weeks of research and then start going out to market or then start talking to your patients. Brandon, did you want to add something here?
Yeah, if you don't mind, thank you for noticing my not subtle body language, by the way. I wanted to add one thing. As you mentioned, I think on the previous slide, this notion of business priorities, and I can't emphasize enough how important this is that where consumer targeting and the business priorities meet has the potential to lead to some really uncomfortable conversations. And what I mean by that is in the past, we would never think about prioritizing a patient with a certain kind of insurance or had a particular clinical need over another one. But first of all, you have to have the information to know where your most profitable business is going to come from by payer, by service line. But then I think there is that internal conversation that has to happen of whether you're going to allow that to affect prioritization. If you're trying to purely maximize financially, you're going to sequence the highest margin, highest dollar procedures from the most profitable payer contracts first, and then work your way through that acuity stack, right? Or less, or profitability stack, or both. I'm not saying you have to do that. That's a discussion to occur inside organizations, but it is not a conversation that marketers are always involved in with their business counterparts in the organization, and they really have to be here because the marketing is ultimately going to be targeting people who were pre-auth and scheduled as well and went on hold, as well as people who are pre-auth and scheduled now and waiting on a summer surgery. Well, how you handle that scheduling may to determine a lot about what your profitability is like over the summer.
Yeah, and that's really important and affects the next one as well, patient retention. And also, there's even options in terms of what guidelines you're going to be using. So Brandon mentioned earlier that we had AHA, ACS, and a number of other associations announced their guidelines for hospitals to reopen on Friday, CMS on Sunday. We've just begun kind of pouring over those, and you can see some differences. So we think it's important that you're using those guidelines, at least from a patient need and acuity standpoint, not to mention what Brandon's talking about. But just to point out one difference, CMS talks about, in terms of PPE, that having an adequate supply of PPE is important. I think I'm using the words literally there. AHA and ACS say you should not reopen your doors unless you have adequate PPE. So a little different bars being set there. And all of these things are important because as you think about those business priorities and how they're going to impact consumer targeting and patient retention, you're going to want to make sure that you're following those in the way that you need to, and that you're letting people know that you're following those guidelines. And this isn't all arbitrary, right? Maybe the most important initiative coming out of this will be patient retention. You've got to make sure you're protecting to whatever degree you can those patients who were already scheduled and who've been postponed, who've been canceled. You don't want those folks not receiving the care that they need to get, and also not going to somebody else who's ready for them before you are. Again, the complexity of this initiative can't be overstated. This is not sending people a letter saying, hey, Brandon Edwards, your knee surgery is now on August 15th. If you are moving people to August 15th and you're sending them communications, what can you do to stay in front of them until then? How can you nurture that relationship? We have never had to think about patient retention as a marketing strategy. You get people in with marketing, they schedule their surgery, mission accomplished, right? And if they can't have their surgery, that's something that the clinical folks often deal with. We are now, for the first time, having to think about how do we keep the people who are supposed to be here and make sure the others that are considering, for whatever reason that we've mentioned, going somewhere else or not having the procedure, stay with us. There is so much that we can do here, and it is awfully complex work. It is probably the top priority in terms of your rapid recovery. But then again, that's just protecting your current share. There is an opportunity here. We said at the outset, the title of this presentation is An Unprecedented Threat, which is what the last initiative is supposed to address, but also an opportunity. Because as Brandon said, in many ways, market share is reset to zero. So if you can get out there in a quicker way, a more sophisticated way, a more effective way, you can actually pull people from other systems. And so you should not leave this opportunity on the table. Thinking about patient acquisition and the typical things that you would normally do, which may include advertising. So here's where that might come into play. You might also use direct marketing, SEM, digital, the list goes on and on. The key is, how do you prioritize those tactics and channels given the COVID-19 situation and coming out of it? Because there are different things that you'd want to do. One example that we use is, a lot of times we recommend folks, in terms of service line marketing, build a long-term content marketing program. Let's target people at the top of that acuity funnel. So let's take somebody who has knee pain. They may not need surgery, but let's give them a lot of content to help them therapeutically with that knee pain, with that joint pain. And maybe in 6 months or a year or in 2 years, when they do need surgery, they're going to come to us. Super smart strategy. Don't have time for that. Do not have time for that right now, because that takes time to nurture. We have to emphasize that mid-level, bottom-level funnel in terms of really trying to drive people in. And this is an opportunity that we typically don't have, to pull people in from other systems. So really important there. Reputation assessment and action. Basically, where's your brand coming out of this? We all know that brands play a huge role in supporting your service line marketing in normal times. And that couldn't be, again, overstated coming into rapid recovery, right? So imagine systems on a spectrum. Some have suffered through this. They've hit the news in the wrong way. They've had deaths, just really unfortunate. The good news is most folks aren't even holding hospitals and health systems in a negative light because of that. They still recognize the heroic work even these hospitals that have been overrun to a degree are delivering. And then others have been all the way on the other end of the spectrum, as we would imagine, held up as heroes, brands lifted, sentiment to a degree that we have never seen before. So where are we at on that spectrum? And do we need to take action to either repair, so that when we go out and market with patient acquisition and to support patient retention makes sense? Or is there things that we can do to go to market with our brand to actually leverage and capture that lightning in a bottle and hold on to it as long as possible? Another thing we've talked about is the heroic efforts of frontline staff. We have relied on them throughout this crisis, and we're going to rely on them in rapid recovery. Most hospitals and health systems we've seen have done a phenomenal job of saying thank you. In fact, that is a lot of times how we're going to market, is with the thank you campaign to our workers. But we need to go beyond thank you. The impact of COVID-19 on these workers is potentially devastating. We're talking about PTSD, we're talking about trauma impact, and not just during the crisis or coming out of it, potentially long-term. If we want these caregivers to be there for us through rapid recovery and beyond, we have to be supporting them. And we imagine something at the level of, many of you have gone through an EMR implementation, and you know what the internal comms effort is like there. We imagine the same level of effort that's all about supporting those caregivers, your staff, your physicians, your nurses, and not just saying thank you, but bringing forward all the ways that you support them: crisis counseling, free meals, childcare, all of those different things. Is that something you're going to need to put in place or want to put in place coming out of this? And then finally, the last initiative is as always, marketing, measurement, and ROI is critical, but maybe more so than ever, because as we move through rapid recovery and we put these initiatives into place, we have to understand what is working and what is not. There's simply no time or money to waste here. And so putting together an effective, ongoing measurement program so we understand this strategy is working, this initiative's not, this tactic's working, this one could be better. Whether it's for patient retention, whether that's for patient acquisition, any of it, we have to be measuring as we go, so that we're continually right-sizing and fixing and repairing and improving to maximize. Brandon?
Yeah, I'd add one thing to that is I think this is where everything Chris said is absolutely right. And I would add to it the component of an agreement in the C-suite about the definition of success. Is it success to merely recapture the volume that we already had that went on pause? Is the definition of success a certain percentage growth in market share? But I think there is a financial element to that marketing needs to support that and be able to measure it. Is it about driving a certain percentage of the volume from certain payers or in certain service lines? All of those kinds of things, that has to come out in the conversation and takes this from just being, is the marketing successful, but is rapid recovery successful in achieving the overall business goals?
That's right. That's exactly right. All right, we're almost wrapped up here, so we're going to be able to get to some questions, just a couple more slides. Just some other things to keep in mind, high level. Again, we talked about all those things we need to know in the assessment part of this. That means quick thinking and decision-making at an operational level. And we are seeing that happen because of all folks, the people in the C-suite and our operational leaders understand the critical need to go out there and do this the right way. But we can't emphasize that enough. And again, we have a list of things we can share that might prompt some of that more rapid decision-making. Consider as much as you can a centralized approach as opposed to decentralized. What's interesting to us is where we first started, hearing from systems that they were anxious to get back out there was from, guess who? The orthopedic surgeons, who were sitting twiddling their thumbs and saying, we got to get back out there. We got to start doing surgeries, probably well before it was actually the right thing to do, right? The challenge here is oftentimes it is those kind of service line or site-focused pressures that drive our marketing efforts. What we want to try to avoid as much as we can is 1,000 tails wagging the dog. As much as you can, there should be a centralized approach that moves out, and again, has to embrace and leverage those business priorities and all the things we're learning. Otherwise, you're going to be in the worst reactive state. We're all familiar with that. And the last place we want to be is answering the phones and trying to respond to all the different people who want to go out in all the different ways. We should be guiding this from a centralized position out. And that takes something like a war room mentality. We're going to talk about that in a second too. If you don't have a war room mentality, if you don't have a war room, set one up. For the next few weeks, you should have this kind of mentality. It should be the thing in balance with what you're doing with the COVID crisis, right? We're not out of that. Most of us are still up here in the peak, maybe starting to tip over here. Some of us aren't at the peak. So you still have to manage the crisis. But at the same time, you've got to take a war room mentality as well to rapid recovery. Keeping in mind, as probably we've alluded to, you're not ever going to have a complete picture as you go through this. Be great when do you ever have a complete picture anyway? But we've got to move really fast, and we can't wait for all of the answers. We can build contingencies into our planning. We can be thinking about, hey, we may not know which clinic's going to open first yet, but here's the plan for when we do know. And we're just going to slot in clinic A, B, and C depending, right? All of this to say, this is your time. If you're a marketing or communications leader on this webinar, this is your time. We have talked for years about our roles and our seat at the table. And you now have an opportunity to show up with everything that you bring and really help in a demonstrable, material way to help your organizations financially. There is no better time to show the value of what marketing can do than right now. So keep that in mind in everything you're doing. We have, just so you know, pulled together an approach to this. We call it the Rapid Recovery Accelerator. We're going to give you an opportunity to get more information on it. We will not belabor this so we can get to questions. But again, to the point that we've got to move fast, we have taken a planning process and built it around a 5-day accelerator timeframe. And the end result of that, we take all of that assessment that we talked about, we look at all the initiatives we talked about, and you have a roadmap that tells you exactly how to prioritize those initiatives and what you need to be doing in each. So we're ready to help. We have to do this with clients. Clients can do this on their own. Doesn't matter who does it. It needs to be done. But if you need help, we're here for you. So I want to give the last 15 minutes to questions, but first, Brandon, you want to wrap it up real quick?
You know, I think your point about sort of marketing seat at the table, we don't have to belabor it. Probably everybody on this call has probably experienced a version of that conversation. But yeah, I think in most organizations, some version of this is going to happen. It's a question of how planned is it, how deliberate is it, how valuable is it, what results does it produce, and frankly, whether marketing is sort of struggling to catch up with that parade or helping to lead that parade. And I really believe that this is not a marketing only initiative. I think if we've not made that point abundantly clear, let me reiterate it here. Lots of important interfaces on the operation side and on the financial side. But marketing really needs to lead this because it is about the combination of the safety message and access message and the nurturing of people who can't have immediate access. And that's going to be serviced from an operation standpoint, but it's going to be communicated by marketing. And I think, Chris, you hit that point well. It's like, this is kind of our moment. Like, there's a lot of things that happen that marketing influences and affects and drives and creates a ton of value. Much of that value may never actually accrue to the marketing department. If we do nothing, I think most CFOs will react the way they typically do in situations like, anytime there's a financial difficulty, which is to slash budgets. And marketing budgets, I think, are wrongly characterized as discretionary spend. They aren't necessarily seen as driving revenue. Well, this is an opportunity to prove that it does. And this is an opportunity to really prove that ROI.
All right. So we're going to get some questions. We've got a number lined up. You should be seeing a poll in front of you that gives you an opportunity to get more information, to sign up for some things. So if you click out of that, you can always see it again by clicking the polling button on your main menu for Zoom. So just know if you need help, if you need more information, that's the place to ask for it. Or you've got our emails on the screen. You're welcome to email either Brandon or I. I'm going to throw out the first question. I've got a couple of answers for it, Brandon, then you can weigh in after, just so I don't put you on the spot right off the bat. One of the questions is, can you give some examples of what we'd say or do to stay in front of a patient? I'm going to give just 2 examples. First of all, we mentioned before the guidelines that are out there, whether that's AHA/ACS, whether that's CMS. We think it's important that you pick guidelines because that gives you a foundation and some rationale for all the things that you're going to do, and that you can tell patients, hey, what we're doing and how we're prioritizing people is based on XYZ guidelines. But when you use them, make sure you take those guidelines and then turn the messaging into something that's palpable for a patient. And the example I'll give is CMS. So CMS has done a great job of listing 5 levels basically of acuity and how to think about where you want to prioritize patients coming back in. And it's a great resource for you to think about using, right? It is just on acuity. It doesn't go to payer mix and all the other things. And that's great. But what you don't want to do is send a letter to a patient saying, hey, Brandon Edwards, based on your surgery, you're a level 3, which means this, right? Don't use the label level 3. You can describe what they are. So if level 3 is, and I don't have it in front of me, but if level 3 is urgency / long-term, that doesn't make any sense, urgency / emergent, something like that, you can say, based on CMS guidelines, your procedure fits this description, whatever it is. That means you are prioritized in front of people who have less urgent or life-threatening procedures, but it also means that there are some people that are in front of you because of that, right? People will understand that, and that transparency is important. You just got to be careful with the language you use. The other example I'll give is how do we stay in front of them? One of the things we've been talking to clients about is the use of virtual visits. which, as we all know, has really increased, thankfully, as a result of this. Reimbursement challenges have gone away. Physicians have embraced it. Consumers are more aware and willing to use it, given the situation. Think about how you can use virtual visits on a proactive way in terms of patient retention. So most of the time we think about it in terms of somebody's got strep throat, they're going to initiate a call, we have somebody to help them. Some clients and systems are actually using them as a substitute for physician visits, which is great. Do you have staff that's capable of using a proactive virtual visit just to check on people, right? So again, I'm using Brandon as our guinea pig here. Brandon's knee pain, his hip pain, actually, real hip pain, has been put off. Is that a HIPAA violation? Sorry. Has been put off to August 15th, right? And so that's understandable. And with the right explanation, Brandon's going to understand that. But could we reach out to him on a monthly basis through virtual visit just to check in? It's not a reimbursable deal. It's just to say, hey, Brandon, how are you doing? Right? We've got some advice for how to deal with the pain. Is there anything we can help you with? 15-minute call, right? So an example of how we can think differently about some of the tools that are in front of us. Anything you want to add to that one, Brandon?
Well, only one thing is I think you mentioned content earlier when we were talking about patient retention, but I think it's a good moment to mention it here too. Is the virtual visit is such a simple thing. Right? It doesn't matter if we're getting paid for it or not, if we're hanging on to that surgical patient. But also, is there content we can supply them that's valuable in the meantime? Can we say, I know you're scheduled 60 days from now. Here may be some exercises that you can do that will help to reduce your pain, or that will aid in your recovery post. Or if you're suffering from other kinds of conditions, here's some dietary suggestions. Here's some recipe suggestions. Whatever it is, it almost kind of doesn't matter on some level, as long as it's something that has value and is directly tied and is relevant to that patient's condition. But what we're really showing them, and Chris joked about the hip thing, but I'm prime example of this. I get to have my first hip replacement, the ripe old age of 50 this summer, and I'm looking at this like, I haven't spoken to anybody in the practice since this was scheduled in January, right? And it's a good practice, and they're good surgeons, and I'm not saying that to be critical. I'm just saying they have such an opportunity to communicate with me about this. I'm not the kind of person going to switch horses midstream, but there are a lot of people that would, and there's certainly a lot of people that would if they thought they were going to have to delay. So I think things of value, that sort of nurturing, is so important. And virtual visit content, ideally pairing them, low cost programmatic ways of maintaining that volume and building that volume over time.
Yeah, I mean, if we are relying on our traditional way of handling procedures, which is, here's your packet of information, you schedule a procedure, you get a reminder packet a week before, or a reminder email or call, hey, make sure your diet's changing, make sure you follow the 7-day steps. We are failing in terms of patient retention. There has to be more we do, because we've been putting people off, and we're going to have to continue to put people off. That's the reality. And so we've got to find ways to connect with them in between. Another question that's come in, Brandon, I'll throw this one to you first. I'll read the whole thing. I think the reluctance, fear to engage in terms of patients coming back might mean that our time to convert from initial outreach to actual patient consumers takes much longer than we're used to. How do we ensure that our leaders understand this and fund marketing efforts accordingly? What might have needed 3 months of funding in the past might require 6 to 12 months now.
Yeah, I think it's a fair question. I mean, obviously, part of what we're trying to do with the rapid recovery planning and thought process is to make it not take 6 to 12 months. But that said, that may be what's required, and that may be how long we have to think about nurturing some people, particularly if that fall, winter, flu, COVID thing is as bad as some sources say that it may be. I think there's a couple answers to this, right? I mean, one is, there are things that we have been doing as a hospital industry historically that we should do less of. And you know in your organization what that is, so I won't belabor it. But there's things we spend money on to keep doctors happy, or to keep board members happy, or because we've always done it, which has got to be like the worst reason ever, right, to continue to do something. And there are things, I think, realistically, that should be deprioritized, and rapid recovery and this work that we're talking about sort of prioritized ahead of that. I also think that there is a need to really have that business conversation with the CFO and in the C-suite around that prioritization, right? And uh, we've all done cost cuts in our organization. We will do more. I heard somebody the other day say something about, low-hanging fruit. I'm like, good Lord, is there any low-hanging fruit left? Like, is there any fruit left on the tree? In a lot of places, we've all been through multiple rounds. But no organization ever cut its way to prosperity. And certainly shutting down marketing in a critical time like this is not going to grow volume. I don't think any rational person would believe that that would be the case. You only do those cuts if you don't believe that it's going to create value. So I think part of this planning process should clarify the value, but that case is going to have to be made, and it's going to be made very specifically. Reprioritization of investment from some areas into this, and a clear acknowledgement of the ROI that's created by marketing's participation in rapid recovery.
Okay, another question. You just brought this up, so I'm going to throw it back out there. What do you recommend as low-hanging fruits? In other words, there's a lot that we need to do, which I think we made painfully clear, but are there things we can do immediately? And I've got one in mind, Brandon, so think of another one. The fears that we brought up earlier. So you can go find our survey results again at our website. Chase has posted a link to that. There are other surveys out there that talk to this. So there's a lot of data on the fears people have. Start writing up your messaging for what people need to hear to overcome those fears for your organization. Whether that's fear of getting COVID, whether that's fear of cleanliness, whether that's it may not even be a fear, maybe a loss of a job and insurance. So how can you help people with that? Can you point them to local resources? Think about what those messages should be and build those out. One of the things that we're doing right now is we're actually testing some messages to see what's going to be most effective in helping people overcome those fears. And so we'll be using those with our clients to help them write their messages, to make sure that that's based on what we think is actually going to work with people. But you don't need to wait for that. You can start building that out right now. Again, we can look to other industries for examples. Look to the airline industry and the videos they've created about cleanliness. Again, it's so odd to me, having been in this field for 20 years, that to talk about cleanliness as your first and most important message. But boy, it may need to be right up there. So there's I think an obvious low-hanging fruit.
Yeah, and I think I should clarify too. When I said low-hanging fruit, I meant on cost reductions. What's sort of not necessarily what's the low-hanging fruit that we can address, from a marketing standpoint, because I think there are some really good things we can do there. So there was some mention, I think, in the question around internal data from orgs, delayed procedures to referral network patterns, et cetera. Yeah, I think here's the beauty. The first that we talked about, 3 audiences, right? Who's been scheduled and put on pause, who's still scheduled and hasn't been changed yet, and hopefully won't be, especially if you do expanded OR hours and you can double up. And then there's the market share that either has been diagnosed and not yet scheduled, or is perhaps in someone else's funnel, right? A surgeon who's a splitter who might be going somewhere else, or a referring physician looking for the right surgeon. The beauty is, in those 3 audiences that we just talked about, we know everything about 2 of them, right? They're already ours. We know who they are. We know how to reach them. They've been pre-auth. They shouldn't have to be pre-authed again. We'll see how the health plans handle that come summer and fall, when MLR starts to jump up for them. But to me, it's like, this is the definition of personalized marketing, right? Like, we know them. We can call them by name. We can address their situation and address them as people. That third audience is a little trickier, right? Those are people who are going to be new to us and will need to be targeted in new ways. And all of that should come out in the planning process. But I think these are the right questions that are being asked. It's how do you get to that volume, but how do you do so thoughtfully and in a highly personalized and cost-effective way?
Great. All right. So let's wrap there. Just a reminder, if you don't have the poll up in front of you, you can click polling. If you want more information, that's the place to do it. Though you can always email Brandon and myself. We've got the emails up there. We're continuing to put out content on this. We've got blog posts up on it. You'll get a copy of this deck. We have more information to provide you. So there's just a lot out there. There's going to be more coming, and people are moving now. So we're here to help, to answer questions. Please reach out if you want to talk to us at any capacity to help, or just if you have questions. And we appreciate you joining us today and hope that you come back tomorrow and the next day for our regularly scheduled daily briefing live at its normal 30-minute runtime. But Brandon, thank you so much for being a part of this.
Yep. Thanks for having me.
And Chase, as always, sir, thank you.
Absolutely. Enjoyed the conversation.
And thanks to everybody out there for joining, and keep up the great work. We will see you next time.